To you all, and warm welcome to this CHESS event on the promotion of good mental health. My name is Hans Martens, and I'm the chairman of CHESS, the Coalition for Health, Ethics and Society, the health program of the European Policy Center, kindly supported by an educational grant from Johnson & Johnson and working in strategic partnership with the King Budawang Foundation. Now, we just had a mental health week here in Europe, and there's an increased focus on the mental health now, I think, from many sides. But there is also an increased role for the EU in health policy in general after we have this new 7-year budget and, you know, all the other plans, EU for health and so on and so forth. And all the experiences from the pandemic has, of course, paved the way for this, or has helped pave the way, I could put it that way. But it does not see that EU sees itself as having a major role in mental health, at least not on a strategic level. But there's always, we understand, a balance between the national states who wants to do their health policy and what the EU should do. But it leaves an open question about what role the EU should play in the future, and indeed how the EU could improve the promotion of good mental health in Europe. During the pandemic, there's been a lot of focus on the physical side of the COVID-19, but I think there's also been an increase in the understanding of the mental illness effects, because people have had fear for the pandemics, because relatives have got ill, because of fear for the economic and social consequences, you know, your jobs and so on and so forth, because of lack of social contact, which has been a problem for many, not least the school children, apparently, who has not been able to go to school and be together with their friends and so on and so forth. But the mental health discussion is not just about the pandemic. I think it's wider than that. It has been there before, it will come after, but it is an issue that plays a bigger and bigger role in our societies and in our health discussions. It affects individuals, but I also think it's important to note the effect it has on society and the societal economy, because the mental illness keeps a lot of citizens away from jobs, from the social and economic life, but also meaning that they demand expensive care in many cases. So we'll hear many opinions today about this issue, and I hope we'll get some good ideas, not least about what the EU could and should do. We have a panel of 5 excellent persons and experts, and I've asked them to briefly introduce their opinions about this subject, and then we can move to a discussion between them and with you, the audience, as well. So we were just joined by Emily Hewlett, who is a health policy analyst at the OECD, and she will tell us more about the analytical work that's been done on mental health at the OECD, I think primarily during the pandemic. Maria Walsh, who is an Irish member of the European Parliament, will give us an insight into the thinking about mental health in the European Parliament, and also about the Commission's opinions, I think, about what the Commission should do or the EU should do. Liuska Sanna, Acting Director of Mental Health Europe, is clearly focusing a lot on mental health and will also have some strong opinions, I'm sure, about what the EU could do. And I can see in the background that mental health matters for Liuska, so I'm pretty certain that we can expect some strong opinions there. Husseini Manji is Global Head of Science and Minds for Johnson & Johnson, and he will tell us about a number of things, including what role the industry could play in the fight against mental diseases. And then we have finally Artur Furtado, Deputy Head of Unit in DG Santé, and he will provide a response and tell us to the other points that has been made, but also tell us what the feeling is in the central DG or this core DG, General Directorate, about the role of EU in mental health. So I'd like to thank already now all of you for taking time to join our discussion today, and let's get started because we have limited time and we have a lot of speakers here. So Emily, who needs to leave us at 3:30, as I understood, I'll give you the floor first to tell us about what the OECD has been doing here, give us some facts, and then also if we have any questions we address to you, I'm pretty certain we'll have to do that before 3:30, but we'll find a way to do that. Emily, over to you, you have the floor.
Thanks very much for that introduction and also for the opportunity to be with you today. I have a few slides to share with you, and really they focus not on what the EU should do necessarily. That's a discussion for the other panelists here today, but rather it's to try to situate the discussion in terms of where we see the challenges, but also where we see the opportunities. And I think the organizers have kindly said that they would be able to share the slides for me, so that's great. The first major point to make is that mental health conditions are extremely common. So when we're talking about addressing mental health, about promoting good mental health, about supporting people experiencing mental distress or mental ill health, we're really talking about most of the population who will be affected either directly by the experience of living with a mental health condition, or who will know a friend, a family member, a colleague, someone they're managing, for example, who is impacted by a mental health condition. 1 in 2 people, we estimate, will themselves experience a mental health condition in their lifetime, and 1 in 5 people will have a mental health condition at any given time. These are estimates that we made prior to the COVID-19 crisis, and as I'll mention in a minute, we think that this situation may have been changed by the crisis. Because of the high level of prevalence of mental health conditions, there are high social and economic costs associated with untreated mental ill health. We estimated in 2015 that these costs can rise to more than a value equivalent to 4.2% of GDP in European countries. But a large proportion of these costs don't come from spending on measures and policies to support good mental health, but they come from lost opportunities and lost productivity because people aren't able to perform as effectively as they would if they were living in good mental health. Could I have the next slide, please? So to say a bit more about these costs, this is an estimate based on 2015 figures, and what we found when we looked at the level of spending and the indirect economic costs associated with mental health problems in European countries is that direct costs, so that's mostly spending in the health system, account for something like a third of the total costs of related to mental health conditions. But actually, the indirect costs, mostly related to lower rates of employment and lower rates of productivity when people are at work but living with a mental health condition, account for more than a third of the total economic costs of mental ill health. We think it's important to underline this because it gives us a bit of a perspective when it comes to talking about how to take action. Because what it really reminds us is, firstly, there's a really compelling economic case to be made for increasing the range of support that you give to people in staying in good mental health and in engaging with people who need support for a mental health condition. So, but it also tells you that the costs of mental ill health aren't just felt in the health system. It's not just about spending to support better mental health treatment and services, but it's also about making those connections with the impact of mental health in other areas of society, in education systems, for example, in workplaces, in social benefit systems, or in employment support structures or support for people experiencing unemployment. Can I have the next slide, please? This is a particularly important perspective, we think, to take during the ongoing COVID-19 crisis. We talk about the COVID-19 crisis, not just about the pandemic, because the health crisis has had very broad-ranging societal and economic impacts. What we've seen is that the risk factors for mental ill health have increased, and the protective factors for good mental health have decreased. So protective factors like routine, social support, structures, engagement in workplaces and education have all declined to varying degrees. And risk factors like unemployment, financial insecurity, poor physical health have all increased. What we've seen is what you could say was a a logical consequence of those changes in risk and resilience factors. We've seen where we're able to measure an increase in the share of the population experiencing anxiety, and we've seen an increase in the share of the population experiencing depression. A couple of extra things to note here. One thing is that the levels of mental distress in the population have not been constant across the crisis. So we did see a fairly immediate increase in levels of anxiety and depression. This figure shows rates which are mostly taken from March and April 2020. But actually, as the crisis has continued into the end of 2020 and the beginning of 2021, amongst some groups in particular, we've seen an ongoing worsening of mental health status, in particular, a rising level of depression. And we've seen that impact particularly concentrated amongst a certain subset of population groups. We've seen that young people have been particularly badly affected in terms of what they're reporting about their own mental health. We've also seen that people experiencing unemployment or financial insecurity say that their mental health has particularly declined, and we've seen slightly higher rates of self-reported depression and anxiety amongst women compared to amongst men. Could I have the next slide, please? So there's definitely a lot to say about what could be done, what more could be done to try and address some of these challenges. But I think it's important to focus on a couple of things. The first big message is that there are things that can be done. We know a lot about the effective ways that more support can be offered. And a lot of the time that makes very good economic sense. It's not just a good key part of access to universal health coverage to increase access to good mental health support. There's also a societal and economic benefit to be had. So we think that there are ways that you can invest in better mental health support that will pay off in terms of the economic impacts. And there are lots of good examples of interventions that represent good value for money, and that actually in some cases where the investment is paid off within even a year in terms of the positive impact it has on rates of productivity or employment or educational outcomes. I've put four key things up here. There are three key things that I think are key in terms of focusing on action to take now. One of them is about promoting, broadly speaking, good mental health for all, so a whole population approach to improving mental health literacy and tackling stigma around mental ill health. I think that starting early is key, so focusing on children and young people, getting good mental health and good mental health education in schools. That an integrated and multi-sectoral approach is key. If we understand the social and economic costs, then that makes this approach even more critical. Good mental health support in schools, in workplaces, in social support settings makes sense because that's where people who need mental health are. That's where the key contact points are, but also it makes sense in terms of offsetting and tackling some of those high societal and economic costs. And finally, there's an urgent need to focus on implementation. So as I said, we actually know quite a lot now about the types of policies and practices that can be effective in terms of improving mental health support, in terms of improving individual outcomes for mental health, and in terms of trying to offset some of those high societal and economic costs. But there's still a big gap in terms of implementing those policies at a scale which will make a big difference in people's lives, in our societies, and in our economies. I'll leave it there, and I'm looking forward to hearing the rest of the discussion.
I needed to unmute. Thank you very much indeed. It is interesting to see how much more it costs for society than the direct health-related costs, which I think is what we normally try to calculate on. And you could also see, I suppose, at the curve that the further you go north in Europe, the more expensive the social costs are actually, and I suppose that's why these countries are in the top rather than because they have a higher frequency of the diseases. I don't know at this point in time, Emily, if you have any ideas about what might happen after the pandemic. We all like to talk about after the pandemic as it was soon over, which I really hope it is. But do you think it will sort of flatten out when people are getting their jobs back and the economy is thriving again? Or did you have any indication of that?
I think it's too early to say. I think that one of the major key points to take home is we have to keep paying attention to what's happening in terms of people's mental health status. One of the positive things that's come out of the crisis is real intensification in terms of collecting information on people's mental health status and the prevalence of anxiety and depression. And that absolutely has to continue, because even if the immediate health crisis, if the situation improves, and I think we probably all agree that it's taking longer to improve than we would have hoped this time last year, the economic impacts, the impacts on people's education, the difficulties that young people might be having to transition from education into work, those are likely going to have longer term impacts, and we know that that takes a toll on people's mental health, and so it's absolutely critical to keep monitoring. We of course hope that there is a return to a pre-crisis normal, but it's also important to stress that the pre-crisis normal wasn't great. It's people still weren't, before the crisis, getting the support that they need. The burden of mental ill health was very high. So even if we're hoping for a return to normal, that still means that really meaningful action has to be taken as soon as possible.
Yeah, thanks. But we'll come back to as we can a little bit later before you leave. Just one issue about the data. You said it's very important, of course, to have the information, and we know that. But we also know that health data are particularly sensitive. Is this an area where you think there are particular problems about data sensitivity, in the sense of, because of the stigmas and so on and so forth? So is it difficult to get the data we need?
I think the crisis has shown us that it's not as difficult as we thought it was. There are a lot of countries who've, so France, for example, has had more or less every 3 weeks a population level survey of levels of anxiety and depression in the population, broken down in a lot of detail by socioeconomic groups. And that is an extraordinary source of information that's meant that population mental health status has been tracked all through the year. When it comes to internationally comparable data, there's always a challenge because different levels of stigma and literacy affect the way people report information about their own mental health. But I don't think that that's a good reason to not do it. And I think that the benefits we get from collecting more information far outweigh the challenges and difficulties.
Yeah. Okay. Thank you very much. Let's turn to an experienced politician, Maria Walsh, from the European Parliament. I suppose you're not sitting there at the moment, but maybe home in Ireland, I don't know. But in any case, the Parliament asked in the beginning of this year the EU Commissioner for Health and Food Safety about what should happen in this area. And I think the answer came back, well, strategically, we don't really want to do anything at this point in time. I don't know if you were behind the written question there that came, or what your reaction was to it, but over to you, Maria. And thanks for joining.
And thank you. And well, I always feel like I'm chasing Emily in all things mental health, because we're always associated, which is a good step from not so much seasoned politician, a very junior politician that's trying to make mental health a conversation point. But thank you, Hans, for your kind words. I just have a little speech in front of me, but I'll keep it short and to the point. And want to first of all say thank you very much for having me in this very much needed conversation. And I'm delighted to see organizations and think tanks like yourself, us in the Parliament, DJ Santi, and wider groups being involved in this conversation. So making sure all touch points are connected and we're moving forward. For those of you who don't know me, my name is Maria Walsh. I'm an MEP from Ireland, representing a constituency called Midlands Northwest, predominantly rural area with about 1.5 million constituents living in across in the northern half of Ireland, bar Northern Ireland, and we're the most westerly point in the European Union. And I say that because often we don't talk about mental health across the entire union. We might hear from certain voices, much needed voices, but we need to make sure the most rural and even in the skyscrapers in our biggest cities, also everybody has mental health, good and bad, and we must discuss. I am just in terms of the EU, I'm co-chair for both MEP Alliance for Mental Health and the Coalition for Mental Health and Wellbeing here in the Parliament. 2 mental health focused interest groups. And the question of mental health is so vast, as you know, that these interest groups tackle quite different parts of this ongoing and growing issue. But a guiding principle for both, for all MEPs invested in these groups, is fully recognizing that people's mental health and well-being depends heavily on a variety of social and social economic factors, and therefore requires a cross-sectional approach. And I was delighted to hear what Emily had shared there, because cross-sectional approach through a variety of EU policy initiatives is very much needed now. What does the role of the EU look like in promoting good mental health? I believe in order to ensure a holistic delivery of mental health provisions to citizens, policymakers from different areas have to talk to each other and work together. It's quite simple. In the Parliament, mental health issues are approached within quite broader topics. So we see through the the Employment Committee on work-life balance, we see through in the Environmental Committee on the impact of climate change has on our mental health, and through the Civil Liberties Committee on mental health in reception centres. So quite broad ranging, but very much needed topic across all sectors. We as policymakers, though, must remain accountable on mental health and bring real life solutions, I believe, to our citizens within a health programme that considers mental health to be as important on par with physical health. The primary objective of my co-chairs and I at the moment is calling for a development of a comprehensive and proactive EU mental health strategy, taking into account, as I just shared, the cross-sectional impacts of different policies on mental health. And by doing so, I believe the EU can really improve the lives of millions of Europeans, inclusive of all those affected by mental ill health, their families, and the services and supports who care for them, as well as their communities that they live in, contributing to a stronger economy, social cohesion, and sustainable development. Quite big buzzwords there, but ultimately, how do we support the person that needs it and their communities that support them in overcoming mental health? Mental health, I believe, and Emily's probably sick of me saying it at different events, it does not exist in isolation. Therefore, its management and treatment cannot be considered in isolation. Mental ill health impacts every aspect of a person's life through education, employment, personal relationships, consumption behavior, access to healthcare and social services. And by not approaching mental health as a holistic priority area, we risk a two-tier society, which I believe we have now, where those who are privileged few, who are in position to manage their mental health effectively, are able to thrive because they have the resources to get better supports. And those who are not able to manage their mental health are left behind simply because of social or economic constraints. It is only by making mental health a priority in every area of policy making that we can offer real solution to people's problems. And this issue is too critical to be dropped even at one level, hence my call out to cross-sectional impact and supports. Just a few more words. While EU governments are slowly responding to citizens' mental health care within their own national healthcare systems, it's slow, but it is happening. I believe, though, very little action is given to the preventative or integrated care within our sectors. And I know Emily had also flagged it. Pupils are missing out on the care from dedicated trained staff in their schools. Most employers don't take mental health into account for their sickness or disabilities policies and procedures. The healthcare system is having to fill these gaps, though, at national level further down the line and step in where preventative measures, I believe, could so easily have handled these cases long before they get to the crunch point. The COVID-19 pandemic has really shown us a glaring need to reflect on how we develop policy relating to mental health. The Commission, for example, has granted 33 million under Horizon 2020 to fund research on behaviour, social and economic impacts of the outbreak response, which is a big positive. One of those funded projects, Respond, aims to identify vulnerable groups affected by the pandemic and really evaluate its impact on mental health and well-being. And we have to capitalise on the momentum of all institutions going through and existing from this COVID pandemic. this is why, and this is where I hope DJ Santi is listening. This is why we have started a call for a dedicated EU year of good mental health. And ultimately it is to raise awareness of all aspects of mental health policy, encourage debate, just like we're doing here now, in our institutions and our member states, and change the prevailing attitudes and the heavy stigma and taboo that we have for mental health right across the EU. This EU year would send a very strong commitment and a political signal from the EU institutions and member governments that mental health will be taken into consideration in all future policy making and creating. Again, at EU level, an excellent example of a modern solution is the Employment Directive on the right to disconnect. And I flag this because there's a number of things going on, as I'd mentioned. This policy spans the areas of employment, technology, economy, civil liberties, and health. This is how we should be tackling mental health policy across the institutions, I believe, with cross-sectional input, private and public cooperation, and innovative ideas that benefit more than just the social and healthcare sectors. We have a unique opportunity to adjust our policies for what the new normal looks like. And I'm going to add my voice to Emily's there of the post-normal was not working for us. The new normal has to ensure that we're bringing everybody with us and that we're inclusive of all and not just of some. Some things will not return to the way they were, like the nature of work, I believe. It is essential that all EU policymakers, including us in the European Parliament, look at future policy through this lens, and we need to rethink our current policies as they stand if we are going to ever solve the mental health crisis that the pandemic has triggered and only amplified in many citizens' cases. Even more treatment and preventative healthcare, we need to see policies that tackle root causes of mental ill health, like poverty, deprivation, discrimination, unemployment, lack of education opportunities. These are the biggest detriments to all our mental ill health. And within the realms of policy making, we have to think laterally across sectors, as I've mentioned, and really create and find a holistic solution for Europeans' whole lives. Just want to finally say and echo a statement I gave at the very first meeting of Mental Health Alliance in October 2019. And I shared, without mental health, we can't have a solid health base. Mental health doesn't see borders. It doesn't see a person's skill, color, orientation, or gender. It doesn't even see their zip code or air code wherever you're living. It affects us all. And it doesn't see where one community starts and one ends. It is our citizens that are at risk if we don't get this right. Ultimately, mental health is everyone's business. Thank you very much for your time.
Thank you very much, Maria, for this engaged talk about the issues here. I think you underlined very much the link to a lot of other things than the disease in itself. We sometimes, or every year actually, in CHES have an event we call Health and All Policies, and we choose different subjects. And here's certainly a long list of things that we need to address also to do something about the diseases. Because I mean, I was sort of thinking, yeah, the EU should do something, but what should they do? But I think it became pretty clear that we need to try to find some of the best ways to prevent some of the diseases. But I also think you implied that there is a need for all individuals to feel integrated. I think there's probably a question here about health literacy as well. Some get better treatment than others, quite simply not because they can afford it, but because they are more or less literate or live closer to places where they can get treated. But I think this is something we can discuss a little bit later on. I'm eager to get some other points at the table here, and I'm pretty certain we'll have some strong views as well here now from you, Liuska. So please, over to you.
Thank you, Hans, and thank you for having us today here. The previous speakers have actually made almost all of my points, so I feel like I could go home. So they made my life, my job here, yeah, too easy. My job here is now very, very easy. No, I'd like to emphasize on some of, I think, the key points that have been emerging, and it's actually great to see very similar perspectives from, so different actors and coming from different bodies. So that's the first reflection. For those of you who don't know us, Mental Health Europe is the largest independent European network organization working to promote positive mental health, prevent mental health problems, and advance the rights of people with mental ill health or psychosocial disabilities. I'd like, first of all, to emphasize what was said. Mental health was a huge problem already before the pandemic and a largely neglected aspect of public health. Now, we have seen that mental health is determined by a number of factors, as they have been very well described by Emily and Maria, so I won't spend time on those. But I think the problem so far is that the main response provided in general was biomedical interventions or medical treatments. So this has somehow made of mental health a disease, an illness that needs to be treated with medicines. And we have seen that there are so many different factors that impact health that we have to go beyond that approach. We think that the response that we need instead is one that rethinks our societies through the lenses of human rights. And this, I think, is the word or the element that I haven't heard so far, human rights. For people to feel well, we need a society that is characterized by equality, inclusiveness, and cohesion. And how do we get there? I think the first thing is really a shift in culture in everybody, but particularly policy and decision makers. So mental health is a public health and a human rights issue. So approaching it mainly from a biomedical perspective won't work, because we need to address all of the socioeconomic and health determinants that have already been described. What else do we need? We have heard that this was a problem already before the pandemic, and it's going to be worsened, and it will be there for a long time. So we need to think long-term. We need to have in place long-term strategies. And I will emphasize another element that has already been described by the previous speakers. The cross-sectoral collaboration is crucial. So if we want to address in a holistic and effective way all of those different determinants, then we need different sectors of to work together, different policies to work together. I think another element is looking at services. We have to promote and support community-based services. The COVID-19 has shown that the services that really have been able to sustain a good support for mental health were community-based services. So services that are close to people, that are able actually to reach out to them, and particularly to vulnerable populations that may not find their own way to support. And at community level, we've also seen this model of cooperation from these different services working together. So healthcare, social services, police, other voluntary organizations. So there was a change in culture there that needs to be maintained, cultivated, and scaled up at all levels. Another element is for us the involvement of users. Now, users is a broad term to indicate people who have used or still use different type of services, but also people, you know, at risk of mental health issues, and really involve them in the planning, delivery, implementation, and evaluation of the services. This doesn't happen enough. And it's really an important element to have good services that meet the needs of people that use them. The next element I'd like to raise, it's already been brought up, it's really the issue of stigma associated with mental health problems and discrimination. Now, we've heard from Emily that it was not so difficult to get data. But I think it's quite another thing to talk about this in a workplace environment, or, you know, even in a family or friends environment. It's still a taboo. It's still very difficult. And so, yeah, mental health literacy for sure. Now, thinking about the EU, I think apart from DG Santé, it would have been good to have other type of DGs, because if we are thinking about a cross-sectoral approach, it would have been good to have, for instance, DG Employment and other ones and other bodies of the Commission. I think there are two main calls that we have for the EU. One is that to ensure that the funding schemes in place, both the old ones, but the new ones, like for instance, the new health program, but particularly the recovery plans, that they allocate adequate funding to address these determinants. So they look at all different employment, social security, access to services, vulnerable populations. So, but we also need to monitor the spending, because unfortunately we know that too often EU funding is not spent according to plans or spent properly. And the other call is rejoining what MEP Walsh already said. We think it's time for a European mental health strategy. We have also been calling for it since 2019. Why a strategy? Because so far the EU has been focusing on identifying and disseminating good practice. And this is crucial, it's absolutely important for implementation. But I think as the EU has stepped up in the coronavirus crisis and tried a coordinated approach across member states, the same should be done for mental health, which is also an emergency in the end. Now we can argue whether this attempt from the EU to coordinate a response together to the pandemic has worked well or not. That's another discussion, but we think it's time for the EU to really step up to its commitment. And in the end, well-being is a principle at the heart of the European project. Let's remember that Article 3 of the Treaty on the European Union states that the Union aims to promote peace, its values, and the well-being of its people. So we definitely feel it is within the remit of the European Union. Thank you.
I have to remember to unmute. Now, thank you very much to you for this. You talked about integrating patients or users. Everybody talks about value-based healthcare, and I suppose we could do that in this area as well. And then the value is, of course, created because we need to take into consideration what are the outcomes that matters for the patient and the users. The question is, how do we go about that, and how do we catch everybody up? But that's a question we could perhaps come back to a little bit later on. But thank you so much for now. Let me turn quickly to Husseini Manji as well, to see if you can do something or can give us some idea about how industry could help, remembering that this is probably a broad and cross-sectoral issue, and it has a little bit more to do with many kinds of solutions and not just the biochemical one. Over to you, Husseini.
Great, thank you very much, Hans, and thank you to CHESS and the European Policy Centre for organizing such an important and timely event. You know, I think that having this multidisciplinary group is so important, because as other speakers have noted, the solutions have to be multidisciplinary. You know, I think we already all talked about the fact that mental illness and mental ill health was a huge problem before the pandemic, which has just amplified things. And what we need to do is build back better, so that when we come out of the crisis, we're actually better in terms of helping humanity with respect to mental illnesses. I think a couple of factors that weren't touched on in terms of mental illnesses that I'll just amplify is, you know, in addition to being so devastating and disabling, by and large, because they hit people when they're relatively young, usually late adolescence or early 20s, then often they can be lifelong. They're the chronic diseases of the young. And not only are they highly disabling, they can also be fatal. So in many, if not most countries around the world, suicide is one of the leading causes of death, especially in young people. And to the best of my knowledge, currently suicide is the second leading cause of death in girls and young women 15 to 19 globally. Other speakers have noted that these mental health conditions affect everything. So certainly social function, occupational function, scholastic function, but what wasn't addressed as much is also physical health. So there's a lot of data to show that if you have a mental health condition, your physical health, cardiovascular, diabetes, osteoporosis, etc., is markedly worsened. And that's one of the reasons why in many countries around the world, someone with a mental ill health condition often dies 10 to 20 years earlier than the general population. Now, some of that is from suicide, but a lot of this is because of the worsened physical health. So, I think it behooves legislators to think about, if you can do something about mental ill health, you also reduce the overall healthcare cost. And coming to that, I think Emily, pointed out the GDP impact, and yet to the best of my knowledge, only 6% of all healthcare budgets on average is allocated to mental health across the EU, which is well below the 10% target. What I thought I'd do is spend a few minutes just talking about what lessons I think we've learned during the COVID-19 pandemic. I think what we've learned is that the pandemic can generate a large-scale burden with, unfortunately, long-term effects, especially as some have noted on specific groups. One is certainly groups which are, predisposed to mental illness already. The second one that was brought up is, people with significant socioeconomic challenges that are even more affected. I think, as we've seen with the testing and the vaccines, governments and healthcare systems have focused on fighting infection itself, which is absolutely what we need. But if we're not careful about really being proactive in thinking about mental ill health, unfortunately, the data from previous pandemics and previous crises shows often there's a delayed rise. So we're already seeing mental ill health. I think it's unfortunately going to get worse. And so there's, these effects could be long-term. And, unfortunately, due to wide-scale underfunding to treat and support those living with mental illness, we really need to take that seriously. As I mentioned, there's certain populations, this affects all of us, but there's certain populations who are at greater risk. As was mentioned previously, unfortunately, like many things in our society, women especially are more affected. And, most data would suggest there might be some biological factors, but probably even more societal factors, sort of women standing in society, the types of jobs women have. I think very important is the fact that, women usually are the caregivers, both for young children and elderly parents. So they've got a lot of stress, not only to perform at work, but also at home. One of the other tragic things in many societies is we know that physical and sexual abuse is not uncommon, and it has a huge impact on mental health. And during these lockdowns and stresses, we've seen domestic violence go up. And I think one of the things, coming back to stigma, often men who are under stress and depressed often turn to alcohol and violence. So it's almost a truism that hurt people hurt people. So we're seeing even more of this domestic violence in women, which is, obviously horrible and is contributing to mental ill health in women. Again, what was mentioned is that our minority populations are disproportionately affected. Certainly, they face the racial discrimination. Often minority populations are often employed in, sort of jobs where they can't socially distance, they have to go to work, they're more likely to know someone who's personally died from COVID. So all these suggest that we really need to do something about it. So what I think we need to do, and some of these things have already been alluded to, I'll just amplify. First, we need to come together as a society to raise awareness, reduce the stigma, and work with everybody to ensure that everyone has better access to resources, treatments, and support. As was also mentioned, there needs to be more of a focus on prevention rather than waiting till bad things happen and treat them. I think what we want to even sort of do is recognize that there are certain populations have, as we alluded to, have been more affected, and make sure while we target everyone, we specifically make sure those people are helped. I think one of the things that was brought up, what COVID has shown us is that digital technologies and telehealth starts to allow us to reach more people, because that's been one of the problems. There hasn't been enough, sort of services. So by using some of these technologies to reach people, that'll help. Obviously, the point that we're making, we need to think about, mental health stigma is obviously very germane. So we need to think about privacy and ethics and make sure we go overboard in making sure that the data is not misused in any way. Coming back to your question, Hans, in terms of what industry can do, I think industry, this is a shared societal responsibility. So industry has to be part of the solution. So first and foremost, in our own house. So we have to raise awareness and reduce stigma around mental illnesses in our places at work, so that mental illness is treated no different from physical health, and people can get the access to treatment they need. They can actively prioritize balancing their mental health with professional lives. One of the question and answers we may come back to is what should we do when we come out of this COVID, but certainly employers could be a big part of it. I do think it behooves industry to really focus more on understanding these conditions. As many speakers said, these are a combination of biological factors, but also social determinants and psychosocial factors. Really understand what is going on and how we can help people, help them from a medical standpoint, from a psychosocial standpoint. And what you were mentioning, Hans, we all of us recognize that holistic approaches are the best way forward. And we've been talking about this for a long time, but let's put our heads together. How can we even develop new models that capture value from improving patient-centric, real-world outcomes like patient well-being, social functioning, and productivity, so we can basically get people the treatment and care they need? One of the things we were talking about is prevention. I think what we really need to do is what was mentioned earlier, go to the schools, really embrace, young people, to really point out that mental health is, obviously even more important than physical health, but at least not less important, and really start to educate people at the school level. Then I think what we need to work on is mental healthness and ways to develop resilience. This is something we should do across society as a whole, but I think we also recognize that some people may be even more at risk. So, in terms of having general solutions and then targeted solutions, if we can understand, who might be at greater risk, and then see if they're starting to deviate. For example, at school, people are starting to have more social isolation or withdrawal or school performance or things like that. Make sure we help them, educate people, their peers in schools, to spot the first signs and, try and distinguish it from regular teenage problems, provide them the help. As we said, awareness, education, destigmatization, those are some of the key recommendations. So I think those are some of the things I'd mentioned. And I hope, as I said, when we get into question and answer, we can also talk about what problems we might anticipate as people get back to work and to school, and what we can do by taking this on as a shared societal responsibility. But I think one of the most important things is this dialogue. We've brought together different stakeholders. We're all part of the solution. So let's work together to make a difference. I'll turn it back over to you, Hans.
Thank you very much indeed. And also thanks for pointing to an additional cost actually for mental illnesses, which is that it often makes physical diseases worse in many ways. But I also think this issue of maybe starting in school is an important one, because we also have to remember that a lot of, I think, bad mental health is created in school because of mobbing, because of social media's effect.
Absolutely.
And so on. So something we can probably go back to.
Absolutely. That's such an important point that, in many ways we talked about the potential benefits of, by educating people with social media, digital, but we know there's cyberbullying, there's peer pressure. Some kids spend all their time on social media. So let's be very thoughtful about using it for benefit rather than harm. Yeah.
Let's discuss that a bit later on. I can see Artur is really jumping in the seat to get in to answer something. But I also know that Emily is going to leave us in 10 minutes or so, probably before Artur finishes. I just wanted to know, Emily, is there anything you want to add at this point? We have a question coming up, but that I'll raise later. It's not directly to you. And can I ask you, perhaps, is there anything in your data that basically shows good examples to be emulated? Do you have any evidence about that, or how is that? And Artur, sorry for that, but I'll come back to you very soon. Emily, before you leave.
Yeah, I'm really sorry I have to leave early today. In terms of good examples, we haven't necessarily been able to flesh out in the data what the impact of the examples are. So at the moment, we're at a point where we can point to examples of good practice, which at a national level seem to be changing various aspects of the game in terms of mental health. So for example, the United Kingdom, to take a non-EU country, the United Kingdom Time to Change campaign seemed to have had a measured impact on attitudes towards mental health and levels of stigma around mental health. That is a measurable example of a policy that can change outcomes and attitudes towards mental health. What we're missing is a good understanding of the extra investment that we need to change the picture when it comes to mental health, and exactly where that investment needs to be pointed. We have some good ideas, so on promotion and prevention, on integrated interventions, on schools, on scaling up access to low threshold services, on making connections between mental health sector and the quote unquote physical health sector. But what we would really like to know is how much it would cost to put in place those programs and interventions. At the OECD, we're very keen to do more work on that, to give more information in terms of how we close that gap, how much it'll cost, and when we'll start seeing the payoff in terms of the economic returns, in terms of the societal returns. But that for us looks like the big black box that we don't properly understand just yet.
It's always good to have the OECD around, focusing on the societal cost, let me put it that way, more a bit broader than the economy, but also to demonstrate the true value actually of investing in preventing some of these issues to appear, because it's not just a question of paying the people who treat or the cost that the health system occurs. It is, as you were demonstrating, only 1/3 basically of the full cost. And I think Husseini has just added to it another cost, which is the deterioration of many other physical diseases because of this. So thank you very much for being with us here today. There's a lot more we could have liked to ask you about, but I understand there was something which is even more important than this meeting. I don't know what that could be, but anyway, there must be something. So I wish you good luck with that. And thanks a million for being with us here today. But you can stay a little bit and listen to Artur, because I'm going to hand over to you, Artur. You're sort of DG Santé is at least responsible, for actions in this area. I've heard some people here actually disagreeing with the answer that your commissioner gave in the parliament about the strategic options, but that you would have expected. So how do you respond to that?
Thank you very much. I hope you can listen to me just fine. I was listening to you with a lot of attention, and it's really a privilege to be at this discussion, and thank you for the invitation. I see many faces that we have known from the past, that we have just recently met during an important conference that was organized by our commissioner on the 10th of May. And my first note would be that we share most of the concerns, most of the wishes, and the ambition that was described here. We may have some differences and nuances on what we should do to go about it, and this would probably not be a surprise. But overall, I think the concerns, the wishes, the ambition, we share them with all of the speakers. Perhaps my first point, I would like to briefly touch upon 4, but my first point would be to share with you that I have been working with the Commission in the area of public health since 2005, and in communication as well. So I've always had a lot of contact with citizens. And in the area of health, this is particularly easy. And unlike some of my colleagues in other DGs, whenever I go to a meeting, whenever I go to a conference, whenever I go to a school, it takes me a few seconds to explain the importance of health. And it usually doesn't take me much more time to convince them that sometimes an international approach and a coordinated European approach to health is actually necessary. I know that some colleagues that work in the area of energy or defense need a little bit more explaining to reach to the same point. I was lucky to work on the joint procurement of countermeasures at the very beginning of the pandemic, and this it's so obvious the purpose, it's so obvious the value of trying to get enough masks or trying to get enough ventilators at the same conditions, in the same conditions for all the member states. This is really something easy to convey. It takes a few seconds to explain, and it gives a sense of purpose to our work. Now, this is the good side to it, if I can put it like this. There's also a more disheartening side to it, and that's when we receive envelopes, physical mail, and emails from citizens that you will I think relate to this, that write to us thinking that of the Commission as being the last resort. They have usually a tragedy in their lives, and they say, look, we have not been able to get any help. This is the problem that we have. What can you do to support us? How can we find treatment? How can we overcome this ordeal? It is difficult to say, as we must many times. This is not the competence of the European Commission. This is something healthcare provision is something that lies in the heart of the responsibilities of the member states. They are very keen to defend them and to preserve them in their own remit. And I mentioned this not as a defensive, as a lame defensive when I'm starting my conversation with you. I mentioned it because it is really something of key importance that we have to keep in mind. And it's also at points at the key of a mismatch between the expectations and the wishes of the citizens and some politicians as well, and the competences and the resources of the Commission and broadly of the European Union in this area. So I think we do have to start by acknowledging that there is sometimes some dissonance between what we want to do, what we wish to do, what the citizens expect us to do, and what we can and have the competences and the resources to do. And the pandemic and COVID only made this worse, as several of the colleagues around the table have mentioned. The second point that I would like to mention is that this doesn't mean that we are without tools, without weapons, and I think that we have indeed been working and doing a lot in this area since years. I will just remember that we have been collecting best practices in this area since the Compass initiative, and even before that, we have more recently established health policy platform. We find this very important as a tool because it allows us to listen to what the citizens and the NGOs and the industry and anyone, any stakeholder wants to talk about this. We have been using this as a fast response tool during the pandemic to try to collect more useful information and sharing best practices already on how to deal with the pandemic in terms of mental health, the mental health impacts of the pandemic. So we have this important tool to stay connected to the ground and to the citizens and to the stakeholders. We've also been using more and more an important weapon, which is the implementation of best practices, identifying for the member states what seems to work, and then giving them access to the financial windows that allow them to implement this at a wider scale. We think that this tool has a lot of potential and a lot of usefulness that has already been demonstrated because it brings things to the citizens with impact quite fast. And I will also mention as an example what we've done now on the 10th of May, which was this important conference that at points had more than 2,000 participants. That was led by our commissioner, and that serves an important point about awareness, about fighting stigma, and about bringing people together. 3 areas that were also mentioned here today. The event, and I'm sorry to repeat myself because I know several of you were very kind to be there, touched upon the 4 important areas: understanding, living, caring, and then acting. And I will take a couple more minutes on this last point. And on purpose, before touching on the acting, we've structured this conference of the 10th of May around testimonials. This was the first thing, listening to the patients, listening to the citizens, to the organizations that have firsthand experience. So this listening component is still there. I've mentioned the health policy platform. Again, at the very heart of the conference, this was there as well in the form of testimonials. Then we had also the identification of promising practices. The OECD has been helping us in this area, identifying and evaluating promising and best practices in this area. For the reaction of COVID, we are perhaps not yet at the level of best practices, but promising, because we need some more time to evaluate them. And then the last bit in terms of organization is the health in all policies, in this case, mental health in all policies aspect that is essential. We've had colleagues from DG Employment there, just to give one example, that spoke about safety and health at work, that also mentioned the importance of tools such as the European Social Fund Plus and the Child Guarantee. I mentioned these as examples to say that we are, again, very much aligned on how much we need to work horizontally and across sectors to do that. And on this point about the conference as an example of our approach, I would finally mention that in the sessions, in the plenary sessions that touched upon action, we also invited the Parliament, European Parliament, to be there. We invited the presidencies, the Portuguese and the Slovene presidencies. We invited UNICEF, we invited Mental Health Europe. Why? Because we need to share this burden of responsibility and also call on some of those that are the most well-placed, the better placed to act, so that they can do that. And here, of course, you will understand that I make a call beyond the Commission, also to include especially the ministries of health and perhaps the ministries of finance of the member states. I would like, on my third point, to mention directly the strategy, because you have all mentioned this. It's part of almost the title and the concept of this meeting today. And as regards EU strategy on mental health, I would like to perhaps be a bit provocative, and I would like to give you two options, option A and option B. I've had some experience with these initiatives in the past, and I'll tell you that I've seen both of these aspects that I will share with you. I've seen initiatives that serve as a lighthouse, as the Commission pointing the way to something very important, bringing the limelight, bringing the attention, the political relevance to the agenda of a certain topic, and also collecting ideas and setting in motion and building momentum in a particular area, and this was very effective. I've also seen option B, sometimes these initiatives taking a lot of time to develop, taking 2-3 years. I don't think you will find this uncommon. I think probably some examples of it may be summoned by any of us. And then in the end, we spend a lot of time fighting over one word here, one word there, a comma here, a comma there. We'll get a lot of aspirational thoughts in these documents, very, 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 very few commitments. And in the end, we have another piece of paper. We have sometimes 2 or 3 pieces of paper, something that is not welcomed by the member states, that they react against instinctively, I would say. And between these options A and B, I think we may find some of the possible outcomes of such work, and I would like to share this with you with a lot of honesty. I think we have to be frank and say that it's not a given that we will go for one and reach one of these and not the other. Finally, the last point that I would like to make is that we have a lot of important action that is going on, and that we'll have more in the future. In the area of understanding better mental health, we have, as usual, a lot of effort from the colleagues in DG Research that have been helping us to fund a lot of important investigation and studies. We will continue to have the listening mode, the health policy platform, to allow us to have a direct link to the stakeholders in this field. This is not something that we are going to abandon. We already have more than 80 organizations that are participating. And we will continue to use this very promising, more than promising, very useful, very effective tool of the identification of the best practices. This allows us also to call the member states to engage, because they are the ones that define where the priorities are. Then we go about and identify the best practices in the areas that they themselves choose. And we also identify the windows, the financial windows of opportunity for the wider implementation of these best practices. Of course, this is not copy and paste. It has to be adjusted, it has to be adapted, but at least we start from a healthier ground. We start from something that has proven to work in some context. And I don't want to bore you, but there are millions already assigned to this, both coming from the last health program of the previous EU budget, and already now in 21 with the new one. So we'll continue with this very operational approach to try to bring impact to the ground as soon as possible. And finally, we are also working on the health in all policies, the mental health in all policies side. We are very, very pleased that the DG Employment was represented at the highest level in our conference. Again, just to give a few examples, trying to muster and harness the potential of working on health and safety at work, the vast amounts of money that the European Social Fund Plus has, and that are directly linked with the member states and how they choose to work in this area, but also the child guarantee and strengthening the prevention approach that is very close to our hearts in DG Santé, across all sectors, across all policies, and yes, across all borders when this makes sense. And this is something that we still want to continue to explore. I have a few notes here from specific things that were mentioned during your interventions, but perhaps I would make a pause here because it might be more interesting to respond to the colleagues that have been in the audience until now. So I would stay here with this, my intervention at this point. Thank you very much.
No, thank you, Artur. This was fantastic, and I mean you're right in the sense that, of course, you're right, that best practice collection is something that you can always do. I mean, that's part in the treaty changes that you can do, but it's also an issue that has not always been uncontested, if I can put it that way, because the easy thing was to basically say, yeah, do that, identify the best practice, and as you said, adapt and emulate. But many member states think that they can't learn anything from anybody else because they're doing it the best way anyway. You know, there's been a lot of jealousy, and let's come back to that at a certain point. I hope, by the way, there will be more on these issues in the health of at a glance process that we are talking about. I know there will be country reports out by the end of this year, so maybe there's something we can look at after there. But allow me not to ask a question, but to quote somebody who has asked a question here. So this is not me, okay? Marcin Rodzinka says, if we refer to EU competence in health, how EU beating cancer plan is different to a possible EU mental health plan. EU can deliver on cancer, so it maybe also can, or so it can also on mental health. It's a matter of political willingness to act. Take that.
I think that is, to a certain extent, a fair point. In the end, everything depends on political will. This, I think, it's a fair point. I think we've seen it in the past, in other areas, in other presidencies, in different areas. What we've seen is that when there is political will, things get done. Now, the only thing where I think it's quite important to make a distinction is that this political will includes the member states. So if the council, if the member states are there, if the parliament is there, the commission is there, then things get done, and we use our remit, a legal remit, we use our financial instruments, we use our imagination to expand the envelope. I think it is a fair point. But the fact that the fact of the matter is that this actually highlights, I think, what I've mentioned before. There has to be the member states' involvement. There has to be the clear engagement of the member states, and this is not always the case. The second nuance, which is an important one with the European Cancer Plan, is that the Beating Cancer plan is very much focused not on defining a strategy, but on actually implementing things, putting them on the ground, putting them. That there is a very long list of implementation, a roadmap of concrete operational actions that yes, again, put the focus on delivering something on the ground. That it's not just about the replication of best practices, but I would say it's a little bit more akin to that than to something else, perhaps.
Yeah. Okay. Having lived with the EU as many years as I have, I've seen, that things you thought this year was completely impossible will be possible next year of different reasons. I would never have thought we got over 5 billion euros budget, for the 7-year period. So you see how much the COVID has done in that respect. So things can be done. There is other questions coming up, and I have more as well. But I just wanted to hear now at this point if any of the other panelists have any questions or points to raise on the basis of what we've heard since they were in particular from your answers, Artur, Maria, Liuska, Husseini. Any issues now? Husseini lifts his hand.
Sure. If I could just, respond to the last comment that was raised up, I do think that's one of the challenges we face, in society, that for whatever reason, and there's probably many reasons, and I think stigma is one of them, is people don't quite get the seriousness of mental health or mental illness compared to, for example, cancer or some other conditions. So I think it behooves us all to really try and educate everyone about this is at least as important. And again, as I was coming back to, the impact on physical health, the impact on productivity, the impact on you name it, is so huge. Unfortunately, in most places, mental health is almost an afterthought, and somehow we need to sort of get people to recognize the importance and work together. One of the things I'm very pleased to be part of, along with the Wellcome Trust in the UK, the US National Institutes of Health, the WHO, and others, we're trying to get something launched called the Healthy Brains Global Initiative that's trying to bring $10 billion of new funding to try and tackle, and although it's called Healthy Brains, the initial focus is on youth mental health, so 10 to 25. And similar to what we've discussed in this, this symposium, it's going to try and address everything, certainly basic science, translational, but also implementation science. Many of us do think that actual implementation, has to be the job of government. But through this initiative, can we really generate the evidence to show that if you have this sort of psychosocial intervention or this sort of medication plus psychosocial, what works in Denmark might be different from what works in UK, Germany, or Rwanda. So I think the time is right for us to come together and basically not take no for an answer, just force the legislatures. We know they have a lot of things on their agenda, but mental health is so important, and I don't think people get it, that this is as important as cancer. Yes, people might not be dying tomorrow, but the impact is actually even bigger when you think of sort of the area under the curve, because this affects young people and is lifelong. So I just thought I'd mention that, okay?
There is a strong point there in the usual saying, what works elsewhere will not work with us, but at least give it a try. I mean, we would never be on the moon if we didn't try to get up there, Sure. So that's one thing. The other thing is, how can we raise attention? I think the fact that, if I may be a little bit cynical here, that the economic considerations that OECD presented maybe could be something that could raise the attention, because as somebody was mentioning, finance ministries are not unimportant in this context. So that might be something to look at. Maria, you unmuted. That means you have something to tell us.
Yeah. Well, Artur never mentioned his dislike or disdain towards our EU Good Mental Health initiative. So I'm taking it that the Commission is on board with that, and no need to retract or come back, Artur. But much to Marten's point, I believe it was, and just to pick up and from Artur's point too there, and link both. It's a case of there has to be political will in order for us to not just see the EU institutions roll in behind good mental health and highlight mental health as a whole. It has to be member states too. I mean, not to segue too far off, but we have an anti-discrimination directive that's been held up in the council for God only knows how many years, because the belief around discrimination, women's rights in particular, is less and less on the political will channel. So unfortunately, while I'm not trying to jump on the bandwagon hands of your cynicism, it's a case of, you know, we need again to lean into, I guess that's what highlights the importance. We need to lean into all stakeholders, everybody on this call, all organizations covering all ages that work within the mental health space, to keep the pressure on. And that's not just at MEP level or commissioner level or CEO level, that's at local representatives across the EU, that's at regional reps as well as national parties. And up to the point you just made there, I mean, utopia for me around mental health is we see through the future of the conference on the future of Europe, we potentially could see, this is a bit radical, but potentially see a treaty change that includes mental health within the competency of the EU. Am I going to see it in my mandate of this year or up to 2024? Potentially not. But you gotta be brave and you gotta call for things, because if we don't call for things and we don't highlight and lift the stigma that's attached, much to everybody's point, we can, you know, if you look at cancer, you know, mental health of cancer patients and the families and communities and the frontline workers that support them is astronomical. So therefore, every disease you have, every condition you have is an element of mental health, which then back to my treaty change point, and I promise that's the last time I mention it. It's when you have a finance minister at national level and at local level, constantly thinking about climate on one hand, mental health on the other, in all funding streams, particularly mental health. I think that's where we see ultimate change and the best deliverance for our citizens. But unfortunately, it takes time, and much to Martin's point, a lot of political will.
Well, you're welcome to mention the future of Europe. I think there was a not unimportant German lady who mentioned in this context that the EU should have broader competences, maybe also in this area here. You know, when I was growing up as a young kid in the countryside in Denmark, the question of mental health was not such a big issue. I mean, people who acted strangely were just having bad nerves, and a lot of them actually went to life untreated for anything, because there wasn't really any will or any ability to do so. And of course, they wasted in many ways their lives. But the cost at the time of doing so were not very high. And you saw on the figures from OECD that they are today. And I'm sorry again, Maria, if I get cynical here, but it costs a lot besides the individual's suffering and so on and so forth. And of course, there are ways to treat this. But I was sort of thinking on one thing, which is about the diagnosis, because if we talk about treating cancer, diabetes, heart failures, and a lot of the other chronic diseases, you know, we can do the IVDs, we can make the test, and we can extract a lot of value for them. We can use big data, you know, to describe some pathways and so on. I don't think it's so easy and maybe so well done in the mental health area. It's something I'd like to hear your opinion about. And then let me also quote, I know that Simona, my colleague from EPC, is helping with some of the questions, but I just saw there were two issues here. One from Han Lee, who says that one issue is about waiting time for appointment, because for all the other, you know, for the cancers, we all know, oh yeah, it's about being treated very, very early, but apparently also on mental health issues. Is that something we can deal with? And then on the best practice sharing, there is a question here from David Hughes, or a comment, because apparently Artur Furtado mentioned at the 10th of May conference a number of best practice areas. One was community services, that means close to the patient, I suppose, multi-level national suicide programs, interventions to tackle depression, and so on and so forth. So there's a question here about what could the next steps be. And what I'm trying to say with all this is, we agreed prevention is important. We agreed there was a link to a lot of various other diseases, but and to all the policies. But what do we actually do here? How can we improve? Where is the best practice that we can maybe not emulate, but at least let us be inspired? What works best here? What can we do the optimal pathway description for treating the patients? Any opinions? Artur, you were saying at the conference you had, oh sorry Husseini, but Artur, you were coming up with these 3 points there. Is that sort of what you have detected from the knowledge about what's going on in the EU?
Thank you for the question and for this introduction to the point. Maybe I can refer to 2 things that are open at the moment that may be useful. One of them is that we will be collecting, we are preparing a document now after the conference that I've mentioned, a document that will collect the best, the promising practices that were identified during the conference or in the preparations for the conference and that were presented there. And these will be available for the countries and for the stakeholders to comment and to try to build upon that. We also have, and this would be my second point, a best practice portal since a few years, where we invite everyone to introduce their descriptions of good projects that have been implemented and that have been evaluated. It's on the basis of this that we provide to the member states in a very robust way the list of ideas that they may be willing to replicate, adjust, and implement at a wider scale, so that there is a double filtering mechanism. There is the political filter. This is the member states choosing, but it's also there is also a technical and scientific filter, because we put to their attention things that have been evaluated, and we have even the support of the Joint Research Center in doing this. So I would invite perhaps the person that has asked the question to pay attention to this collection of best practices that will, promising practices that will come from the conference, and at the same time to visit our best practice portal. Thank you.
Thank you very much, Husseini. You were in there, but
sure.
Yeah, can I just ask also if do you think I'm right in what I said about the diagnostic opportunities here? Are we weaker in this area?
I think there's no question we're weaker, but there's still a lot we can do. So, I'll just take a step back and say, from my standpoint, and as we discussed, several times on this discussion, all health conditions are a combination of biology as well as psychosocial factors, et cetera. So for example, you could have some of the genes for diabetes or high blood pressure, but if your diet and exercise is okay, you're okay. Conversely, if you develop high blood pressure, if it's mildly high, diet and exercise will be good enough. On the other hand, if it's pretty bad or your diabetes is pretty bad, then you take medication as well as the psychosocial interventions, et cetera. And I think we need to think of mental ill health and mental illness the same way. So I'm not trying to give a biology lesson, but what sometimes people don't appreciate is that the genetic factors for things like schizophrenia or bipolar disorder or recurrent depression is actually stronger. There's more of a genetic component for those conditions than there is for breast cancer, heart disease, diabetes, et cetera. The good news is that the genes are not what we call deterministic. So they don't guarantee you will get illness, but they put you at risk. So coming back to your question, it's certainly things like diagnosis is more difficult, but I think we're getting better. So if you can, for example, as we said several times, focus on young people and using, either digital means, we just even things on their smartphone, are they socially withdrawn? Are they getting out more? Are they sort of, searching on the internet how to commit suicide, and obviously all this needs to be done with privacy and thoughtfulness, et cetera. You can start to see who might be sort of going downhill, because similar to other conditions, the sooner you can intervene, the better. If you can identify people early, in what you said about big data, using physician notes, all kinds of things, you can extract information. If you can intervene earlier, it may be, psychosocial intervention. On the other hand, some people might need medication plus psychosocial. So for example, the person you mentioned in Denmark, if they had something like schizophrenia, their life basically went downhill. So if you could identify them early, treat the hallucinations and the delusions, then help them with their lives, work rehabilitation, going back to school. Those are some of the things we need to think about. And as I said earlier, get to the schools where we can raise awareness that mental health is just as important as physical health, and there should be no stigma or shame, and encourage good behaviors and resilience, et cetera. But if people are ill, then provide them with the best treatment. So it's certainly very difficult, but I think it's, this is such a tragic situation for humanity. We all have to come together and help.
Liuska, I'll give you the floor, provided that you will also address two issues. One is the question of equity or equality in access and so on. Have you any experience about inequalities in this area? And the other thing was the question of waiting times. Is that something that, now the question was about Germany, is something you meet across Europe?
Yes, of course. So in relation to equality and inequalities, absolutely. It can relate to vulnerable populations because they are in a socioeconomic disadvantaged condition. We have seen that people who already have a psychosocial disability or mental ill health have more difficulties to access employment, to get services, and other things. So it's definitely an issue. With regard to the waiting times, yes, it varies across countries, within countries, but I think I go back to my statement of supporting community-based services because they really can provide quicker and more tailored responses. I'd also say that we need to look at the potential of telemedicine, which has already proved itself in other areas, but it's sort of just starting now in relation to mental health. And I think before the pandemic, only 3 countries had actually telepsychiatry programs, operative. And the other countries had to improvise during the COVID with different results. But we need to look into that. There is also artificial intelligence coming up, which is looking into different ways of, detecting mental health issues. So I think there are different things that can be done, but I'll go back to one of the points you made before, the good recipe. I think there's no one good recipe. We've been hearing more and more in the last years talking about personalized medicine. And so we also need to talk about personalized, mental health services, because even though the different determinants are the same for everybody, the way they intersect and impact on an individual is different. And that's why we promote the not even the involvement of people with these problems. We go far by talking about co-production, so that the services are really thought through a co-production approach.
Thank you. I was wondering if Maria or Artur wanted a last word. You have 3 minutes to share.
That's a load of time, Hans. But it just to pick up from one of the questions from Han Lee in terms of waiting time, unfortunately in Ireland, a 4-week appointment is quite short. That's the sad part. And when we talk about best practices, implementation, this is where it needs to come in, and we need to move on it faster. And much to Artur's point, I gotta be nice to him now because I might see him at another event soon, but but much to that point, it's so much work goes in, and then I see it here on a daily basis in the Parliament, like you're arguing over an end, they, but, and a comma. And it just dilutes the work that actually needs to happen in order to get the speed down to the citizens at hand. We are seeing on a national front some really good stuff going on around tele support, and I think that has huge impact. A couple of years ago, well, it launched officially actually before COVID, a psychiatry line through telehelp linked to our A&E services, which actually was really, really good. So if someone presented, our issue is we just don't have enough people coming through the careers avenues into our mental health spaces, which I think is another thing that's important to highlight too. So there's a couple of different angles there on a national as well as European front. Not to ignore your point around the commerce piece, it will cost money. But if you look at the likes of the Finnish model in the preventative care, putting in really good school systems in early learning around the language of mental health and well-being, feeling comfortable in owning their emotions and talking about them within their peer system at such a young age, is certainly the best preventative action that you could ever ask for. And that's something that I often talk about, the Finnish model. But last but by no means least, these conversations need to keep happening, and not just in a vacuum. It needs to happen through, I believe, the Conference on the Future of Europe, that we're actually going out as parliamentarians, as think tanks, as commission, going out to our communities and asking the questions, and really working that not only are our citizens' voices feeling heard, but we're actually coming up with the best care practices, and you begin to put the pressure then on the political willingness, and that builds up. But I leave it there, and thank you very, very much for the opportunity.
And again, you took the opportunity to mention the Conference on the Future of Europe once more. So we noted that. Artur, any final comment before we leave? Brief, please.
Thank you. I will, 4 telegraphic points. One, to say how important it is to bring the issue of inequalities to this discussion, unfortunately. The second one, to mention that our effort to work on best practices, and I know this is something that we all share, is to try to avoid a temptation or a problem that we all have, which is sometimes settling for the minimum common denominator. We would actually prefer that we all approach the first in class. And the system in Europe sometimes is more conducive of us achieving the minimum common denominator. Let's hope that more and more we go for something that is even better than that. The third point, to agree that prevention would be key. We are trying to work, just to give another example, with the OECD, so that we give the argumentation to the ministries, all of them, so that we can have more done on prevention, so that we save suffering and we also save the budgets. And the final point, to say that, yes, please, let's work together, not just because it sounds nice to have these words at the end and at the beginning, but because it's the only way of getting things done. Thank you.
Thank you very much. We have exceeded the time by 1 minute, and that actually saves me from making a conclusion, which I think would be very difficult to do, except to say that I think we have pointed out to a number of areas here where we can see how important this is also for the societal economy at a larger scale. I think we have identified prevention as something very important, but also something a little bit difficult, where we have to search and look for better ways of doing so. And I suppose this is something we can do and maybe come back to also maybe in the context of the Health in All Policies program that we do, because we have also identified a number of links here to various sites. So I'd like to thank the attendees who has been sticking with us this afternoon for this important discussion here. I also think it's appropriate to thank our participants. Thank you very much, Artur. Thank you very much, Maria. Thank you, Liuska, and thank you, Husseini. And also in absence, Emily, but for her introduction. It has been great to moderate this. Thank you for your contributions, and I hope we can pick up this important issue at a later stage. Thank you very much, and goodbye, and have a good rest of the day.
Thanks.
Thank you.
Thank you.
Thank you.